CF even before we'd ever talked. And then, we hung out and became fast friends. Dr. Dandekar, my question to you is when will the CF Foundation allow us to move to second base? Nah, just kidding.
Or
We're
first
very good.
base. We haven't even gone
Yeah,
to first
that's
base.
we haven't even started. No, I'll leg over from that. What I mean is, when can CFers actually hang out in an enclosed space? Obviously, that's been like a no-no, and it's kind of tough because we do all these really cool events, but there's only one CFer there. So, is there a chance that that guidance changes in the near-ish future?
Um, I can't speak for the CF Foundation, and I think uh, I think it's unlikely that the CF Foundation is going to change its guidance for its own events anytime soon. I do think you raise a question that I don't think I think we don't know the answer to, which is for people who are on corrector modulators, what is the risk of transmitting bacteria to one another if you happen to be in the same enclosed space? And maybe we'll learn that over the next few years. Until somebody figures that out, I think the likelihood that the formal guidance would change is pretty low. If you go back, if you go back 30 or 40 years, there's a there's a pretty significant and kind of disappointing history of people with CF transmitting really bad bacteria to one another and causing all sorts of problems. And so I doubt the CF Foundation would change its guidance on that. Um, I will say that, I the I don't I just don't know I don't know what the answer is. And it does at some level, it I find it frustrating that the official guidance is to take autonomy away from people. That it, the bias is to say that you can't do something. Um, so I understand I understand where they're coming from, and I definitely understand it for their own events. But uh, but I do think it's right. There's just the the rule means that you can't meet each other in person in an enclosed space under most circumstances, and I get that that's frustrating. And
I can pop in on this one as
yeah,
well.
yeah, there you go.
I am not like at a top level in the CF Foundation or anything, but I have heard that we are having some discussions on possibly
Yeah,
changing protocol as people are living longer and getting less infections. But then, of course, we also have to think about, people who modulators aren't working for, and think about that as well. The CF Foundation does have our protocol where we can't invite more than one person to an event. But of course, we're never going to stop anyone from coming to an event if they really insist on it. That's the case that's happening with NACFC this October, the North American Cystic Fibrosis Conference. It is the event organizers are only going to invite one person with CF, but if more people are interested in coming, we aren't going to stop them. We just like them to um, show that they, have like a tag or like wear a purple shirt or something so that they can self-identify for other people who might not feel as comfortable with CF, being around another person with CF. So
For sure, that's great background. Thank you for that.
Yeah, I actually have something to add to that. So, from a person who doesn't have modulators, and a lot of the literature is talking about how wonderful of a time it is for people to have CF. When those changes law, I would assume not, I don't know, actually, I can't assume, but I know for us, we would probably withdraw even more because we would know it would be more dangerous for us to be
yeah,
around other people. And it's interesting because that actually came up this last week. I was interviewing with Seattle Children's. They have like a quality rating type of panel for across the country to see what's best outcomes. And they would like to have parents on the panel as well. So I was interviewing for one of those spots, and that was one of my biggest limitations is that I probably wouldn't be able to go speak at conferences on behalf because I'm a parent, but I'm also a person with CF. So that kind of makes it more challenging for Seattle Children's to have a person like me on that space as a parent versus another parent who has a child with CF. And so that's the interesting thing to think about, like how that actually prevents the hospital, if they choose to choose somebody else that can go to more conferences in person, because the voice of this person who doesn't have modulators isn't even in the room anymore because of that speculation. So it's a complicated thing, but it's really hard to not have treatment either. So I guess I would wonder what would that message be like for the people who are more vulnerable.
Yeah, that's really good insight, Nikki. Thank you.
Has there been any information, just anecdotally, or I don't know if there's formal official studies about whether people with modulators can, like, are we seeing people transmitting between each other if there's environments where people are breaking that rule and are around each other?
Yeah, I think that that's a great question. I think people actually don't do that as a general rule. So it's people with CF have for a lifetime, at least until the last 5 years, made it a very strong habit to get nowhere near other people with CF. And I don't think that habit changed a lot in the last 5 years. So we do not have information about that. I don't think there have been enough chance encounters between people where we would have that kind of just enough knowledge about what happens on a population basis.
And it's interesting. I worked with somebody for 3.5 years who had or has cystic fibrosis. He's now in a different state with his double lung transplant. But I'm a very mild form. And so I didn't feel the implications of it because I'm milder, but I literally spent a lot of time inside serving tables with this other guy who has cystic fibrosis, and I just didn't know I had it. So yeah, I don't know.
Yeah, and like most things, I think it's a lot about the actual proximity, and then how much time there is, and then how much of a burden of infection there is in people, and then what the lung function is. There's just so many variables that would feed into that it's going to be tough to have a rule for everybody that works for everyone.
Dr. Dandekar, quick question. So like Rach and I are going to go on a bike ride. That feels pretty safe. We're outside.
Correct.
But if we get in the same car or an elevator, where does or go into the same house? Is it sort of like, should we think of it as the 6 foot social distancing rule as your guidance or as our guidance?
Yeah, there's a sort of a story of notoriety in the CF world of some kids in the New York, New Jersey area in the 80s who got in a car to go to the Jersey Shore, and one of them had a terrible bacterium, Burkholderia cepacia, and then all of the kids in the car got it, and then they all died from the cepacia syndrome. So cars are a definite non-starter for that. And I would say elevators probably are much shorter, right? Unless you're in an elevator for a really long time. But it's the same thing. It's this combination of, proximity and time and recirculated or lack of circulated air. I don't think riding a bike next to somebody is a problem at all. And that's why we have the stair climb, right? You can run up and down at T-Mobile Park without a problem. I I I don't think being in the same room, unless you're pretty far apart, is a good idea. And with all the things that we talked about earlier, I just don't know. I mean, I can't tell you honestly that I know what the risk is.
Yeah.
We know what the past held for people.
Cool. We'll keep it outside. Rachel, turns out we're not going to my apartment to the upstairs rooftop deck because that involves an elevator.
An elevator.
Dr. Dandekar, unless anyone has any other questions, I would say maybe do
Yeah,
you
I'm
want
happy
to
to.
answer the ones
Yeah, I've got these questions, and I know it's getting recorded, so I can. I'll just add, and people can listen later. One of the questions was actually about uh, CF-related diabetes and the use of metformin. So it was, is metformin commonly used in the treatment of regimens of CF patients, and then under what conditions, and then what are the pros and cons? So that's the first question I have here. Metformin is not commonly used in the treatment of people with CF, although it is increasing in frequency. So if you asked me that 10 years ago, I would have told you under no circumstances should get somebody with CF get this drug metformin. That has changed actually considerably since in the last 5 years. Metformin works in two different ways. One is that it prevents the liver from making more glucose, something called gluconeogenesis. And then the other way it works is by sensitizing cells to insulin. So it takes the insulin that people's bodies make and makes the cells in the body more sensitive to it. So metformin really works for people who have resistance to insulin. So your body's making insulin, and for whatever reason, the tissues just don't respond to it. And for most of my career taking care of people with CF, that insulin resistance has not been a problem amongst people with CF. And then there's been another layer of that where the metformin can cause some acid-base issues where people get basically acidic blood, something called an acidosis. But in the corrector modulator era, we now have people who have evidence of insulin resistance. They're making enough insulin and their bodies just aren't responding to it the way that they should. And for those folks, my diabetologist colleagues do sometimes prescribe metformin. It's still a minority of our patients, but it is a treatment. There's this question about the pros and cons of it. Metformin is this drug that, if it works well for people, it's kind of amazing. It causes people to lose weight. It increases insulin sensitivity. It can improve overall health. People are studying it for pre-diabetes and longevity. It has sort of a variety of effects. It doesn't always work well for people, and because of the central problem in cystic fibrosis, which is this chloride anion channel problem, people are more high risk of getting lactic acidosis and having other problems from metformin. So that's a con. I haven't seen problems with it, but I also don't have that many people who are on this medicine. So that's one question. Another question that I have that Nicole sort of alluded to, which is, are there any improvements to Trikafta or advances similar to Trikafta that are showing promise and might be released within the next 3 to 5 years? I'm not sure that there are major improvements to Trikafta or Alyftrek that are on the horizon. I know Vertex is always trying new agents, but actually for the 3-drug combination, Trikafta or Alyftrek, it has to be better than those. So it just becomes a harder and harder drug development problem to solve. Not whether or not you can, but it just has to keep getting better. Um, there are um, there are some agents that have promise for people who have uncorrectable mutations, and the ones that are the most advanced in the pipeline, they're in phase 2 trials, so they're still a couple of 3 years away at best. Are ones where mRNA for the CFTR is delivered to the lungs of people with cystic fibrosis. So there are 3 different companies working on this and with different formulations of getting the correct version of the CFTR mRNA into the airways and lungs of people with CF, with the idea that the mRNA will just basically provide the the material to make the correct protein and sort of reverse the process. I think what we both don't know how well the delivery is going to work and how durable the effect will be. But there's at least enough experience from the mRNA vaccines that we know that people can, get repeated deliveries of this without having it go completely sideways. Nicole has raised her hand. And you're still muted.
Oh, you're muted.
Sorry, I'm making sure I'm on flower patrol so she doesn't pick all my flowers. I had a question around that because I'm reading a lot of stuff about canceling mRNA vaccines for
Yeah.
COVID. Is that going to impact anything with the CF mRNA process, or is that, hold on, Anna, or is that going to just be, no, you can't pick those. Or is that going to be just like a side thing and it won't impact the pipeline for that type of treatment option?
I at the moment, I think everything that's going on with mRNA vaccines is bonkers, and I can't guarantee that more bonkers things won't get done. But at the moment, the pathway for drug development for these mRNA deliveries for CF and other diseases are not in the vaccine pathway. They're in sort of the drug development pathway. And it does matter because the way that the FDA approves vaccines is separate than the way that it approves drugs. And so for the moment, things that use mRNA technology to create a drug as opposed to a vaccine are unscathed in this process. And then the that's a that's been a huge problem for the vaccines because the regulators have basically said we're not doing this, and so there's no way to get the drug or the vaccine approved. In the case of the mRNA for gene therapeutics or something like gene therapeutics, that hasn't happened. So there's still the pathway to get it approved. And I know the CF Foundation has maintained its investment in the development of those drugs. So I can't with any confidence tell you that that's going to be the situation a week from now, but at the moment it is. Yeah, and then there are other advancements that are in the pipeline for people with mutations that can't be corrected or people with nonsense mutations, including directed therapies for specific stop codons, or just generally having something called read through where you skip over the stop codon. Those have been the first type of that is more promising, but is earlier in development, and the latter ones have not generally been successful. They also create if you start skipping through stop codons, most of us have stop codons for a reason, so that cells stop making proteins when they're supposed to, and you skip doing that, you create other problems. So I'll answer other questions. I've got another couple here on the sheet, but I'll take other ones from the group.
Uh, I'll jump in. Have you changed your tune on since we talked last week on nicotine? Can I do my
No.
nicotine meds?
No.
No new research has come out to say that it's healthy and supportive.
I cannot advocate for people using nicotine.
Still no.
Still no.
I'm going to talk with RFK about that, okay?
Okay. You can do that. Yeah, I can't recommend it. Sorry.
The background is, and I'll share it because I can. In my doctor meeting last week with Dr. Dandekar, I told him my one vice is these 2 milligram nicotine mints. Look, I used to be a heavy drinker. Okay, so pick your poison, right? Now I'm on nicotine. Can I have this one evil? And Dr. Dandekar's trying to take that away from me too. So we're just beefing. It's fine. It's fun. I'm trying to cut back. But he says it's not good. And I just
Says no.
struggle with it. But here we go. Look at that. Still alive.
I cannot stop you, Kevin.
You have free will.
You are an adult.
This is true. This is true. Anyway,
Decision making.
let's go to more relevant questions.
Any others from the group that's here? Yeah. I have another one from email about rectal prolapse. So somebody sent me an email saying rectal prolapse is one condition that CF patients experience more frequently as time goes on. It's easily manageable at home. What should we be watching out for as we age? And then the follow-up question is surgery to deal with the condition inevitable? And if so, when would that be expected? So I think the rectal prolapse is actually, it gets less common for people with CF as they age in general. So it's a problem for kids and not so much for the cohort of all adults with CF. It does affect some people. If it's happening more frequently, you should bring that up with your doctor. The thing to worry about with rectal prolapse is that if it becomes more difficult to reduce. So, it's a physical impairment that's uncomfortable and distressing, but if it can be reduced and pushed back in, that's not a problem. If it is happening more frequently and it's getting harder to reduce, that is a problem. Surgery to deal with it is not inevitable. Most people with CF don't have surgery to deal with this problem, but it does happen sometimes. And it really happens when we worry about basically that it can't be fixed easily, or if the tissues are the viability of the tissues, the intestines are threatened, or it's just happening so often that you can't manage anymore. So I don't that this was asked over the internet, but if it's accelerating or it's becoming a personal problem, that's a good reason to talk to your doctor about it, and then maybe see a surgeon.
We literally had to ask our neighbors for a cup of sugar over that topic.
Oh, really?
For my daughter, because we didn't have any unprocessed or processed fine sugar in the house. But yeah.
Yeah, it's tough. It really does affect kids more than adults, but it can affect adults. That's the group of questions that I got over email. Thanks to the people who sent them.
I've actually got one more.
You've got one.
Kaylee, please, I've monopolized.
Are you sure? Okay.
Yeah.
I just had a general question about things in the pipeline as far as like CRISPR research and that kind of stuff. It's a very broad question, but I was just wondering if you had any insight into that and kind of what that looks like or what things are being tested, I guess.
Yeah, so there's a host of things that are being tested that have the goal of fixing the genetic defect of CFTR in people with CF. There are two major obstacles to effective therapies overall, and one of them is that CFTR is expressed everywhere. So you have I'm a lung doctor, but of course you all know that CF affects many organ systems, not just the lungs. And actually, as improvements to treatments for lung disease have come along, other ones have become more prominent. So we have the gut, and we have the liver, and the pancreas, and lungs, and actually even the nervous system. All the tissues express CFTR, and so ideally, you would fix it in all of them, not just one. So that is one obstacle. The mRNA approach has basically said we're going to try and fix it in the lungs, based on the appropriate calculation that that's the organ system that causes the most severe morbidity and actually mortality in CF. And then the other one is which cells to target. And so if you ideally, you would deliver a therapy to some sort of cell that would sort of divide and sort of regenerate within people who had been treated, so that you would have a durable effect, not just a one-time thing. And this has worked for a similar one gene disease, as sickle cell disease. And people with sickle cell disease can actually be cured now, because we can take bone marrow cells, change the gene for hemoglobin, and then put it back into people. And those bone marrow cells reproduce within the bone marrow, and they now produce red cells that no longer produce the sickling hemoglobin. If we did that with bone marrow cells for CFTR, nothing else would change. You wouldn't affect the lungs or the liver or the pancreas or the nervous system, because those all developed when we were all fetuses and embryos, and they're not tied back to the bone marrow. So we have to figure out a way to get the gene to those organs and have it stick around. And that's been the problem. It's actually not this, it's not the it's not the matter of gene editing, which in the last 10 years has actually been solved with CRISPR, as you mentioned, Kaylee, but it's how do we get it to where we want it to go, or to, where we think it's important, and then how do we get it to stick around in a way that it lasts. So hopefully the mRNA things that are in the pipeline for the lungs actually show that we can do that, and that maybe it'll just take repeated doses of things. People with CF have taken repeated doses of things for
their whole life,
longer than I've been a CF doctor. So I think that would be fine, but those are the blocks.
It's very fascinating. It's it's really it's encouraging. I mean, hopefully,
and these the breakthroughs on this front happen unpredictably, right? It seems like nothing happens, and then suddenly somebody has solved a problem, and then you just move forward. And it's not like drug development where everything is incremental. There are these bursts of huge advances. So hopefully one of those comes along soon.
Yeah. Cool. Thank you. That was super helpful. I never really understood where we were at with it or what the challenges were. So that was super helpful. Thank you.
I think we're getting there, but there's still some obstacles.
Some hurdles. Yeah. Makes sense. Cool. Thank you.
Yeah.
I have another question around the antibiotics.
Yeah.
Has there been any new, I know that there was like the Pasteur Act that was trying to get passed for a while and things like that, but has there been any new leadway on finding, more of those resistant bacteria, ways that we can resolve them when the antibiotics aren't working?
Yeah, there are a couple of drugs in the pipeline that are looking at treating bacterial infections in different ways. There hasn't been a new antibiotic in some time, actually. There there was one a few years ago called cefiderocol, which works by a new mechanism, and that's like the one in the last several years. There are a few drugs um, that work to break up the biofilms that bacteria form. So one of the issues in CF, of course, is not only is there an infection, there's like this tenacious aggregation of bacteria that we call a biofilm, and there have been some efforts to disrupt those biofilms, right? To break up the physical aggregation of bacteria, and that has two benefits. One is that it's probably easier for people with CF to just cough that up. But then the other one is that by breaking up the biofilm, you actually give access to the bacteria back to antibiotics. So biofilms actually physically impair the ability of even the antibiotics we have to work. So this is it. So these are in the pipeline. I think that it's actually encouraging. It's encouraging to me because it's a completely different approach, and so it's unlikely that we're going to have a whole bunch of resistance from the get-go, and it might make the antibiotics we have work well again. But we'll see. There's some trials enrolling in that actually right now. All right.
I could jump in with one more question. Can you hear me?
Yeah.
Cool. I'm really competitive, and I don't want to give too much, personal information out, but my arch nemesis from a CF standpoint is Marco because he beats me every year at the stair climb. And he just had a baby, and now I'm jealous. And so I'm also dating, and I'm telling ladies that I can have a baby. It would just cost more money. That's right, right? It should be, that's correct in theory.
It's no, it's correct. Most 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 women who have CF are have approximately normal fertility. And men with CF, 97 or 96% of them are infertile because they don't have a vas deferens. There's no connection between the testes and the prostate. That's obliterated in embryogenesis, so it's congenital, like you're born without
Oh,
that vas
interesting. So it's
deferens.
not that the channel's plugged, it's just like it's
It's
not even
gone.
there.
Yeah, so the sperm, men with cystic fibrosis make sperm normally and they can be extracted, and men with CF can have children by in vitro fertilization. And in our clinic, this has happened dozens of times. This is just not a, it does, as you said, cost more. Although for medical indications like this, often insurance will pay depending on the insurer.
Oh, that's
Wow.
fun to know.
Depends. It depends. It depends on the insurer, right? And
Okay.
it has that.
I totally thought that it was what Kevin said, that they were just plugged and like that was the reason that I didn't
Yeah,
realize there was no physical
there's
connection.
no physical connection, and I think though, I'm going to go out on a limb here. I think what happens is it gets plugged as it's developing, and then it just gets obliterated
Mm,
as it's developing.
it just can't
It
Yeah.
just doesn't. But there's it's not that it's there and it doesn't work. It's not even there.
Wow.
So we're basically born with a vasectomy.
That's correct.
It's kind of a perk in ways. So
There you go.
I mean,
cool.
yeah.
Yeah, a glass half full on this one.
I
No,
would
it's
assume
not
that,
full of sperm, but it's full. Okay, sweet. Thank you very much.
I would assume that's something that you can find out, like get some sort of test for to see if it's there or not.
Yeah, so there's a very simple ultrasound test to actually just determine if the vas deferens is there. Yeah, so we can be done.
Does that test, but would that verify that yes, or I guess we're not really concerned about the sperm being there and or of quality. It's what you're saying is the test verifies whether or not the channel was obliterated.
Correct. Yeah.
Okay. Well, I've
So
never had a
interesting.
pregnancy scare, so we're just going to assume it is obliterated.
Obliterated.
Or that you're practicing safe practices.
Yeah, one of the
Right.
two.
Definitely that.
I have a COVID vaccine question.
Yeah.
I'm assuming last time we spoke, guidance is still for people with CF. You can get it once a year. That's a good thing to do. Would there be any reason to do that twice a year? Because I know the efficacy wanes after a few months. And if like they come out now in September, because there's usually that little bit of a wave in the fall. And then that puts us to a little bit of a waning efficacy come the winter boom.
Yeah, there's that's correct. So there's sort of a 6 month durability of the vaccine, and then the efficacy does wane. The trick has been that in the last several years, there's been a new strain that's emerged every spring that has sort of not been covered by the vaccine from the previous fall. So I think it's important to get vaccinated against COVID in the fall, sometime around now or maybe October. But like last year's vaccine doesn't cover this year's circulating variants. And if you'd gotten a booster in May, it also wouldn't have helped for the new variant that we have. So, and that's been true for a few years running now, going all the way back to the Delta variant, if you remember that one in 2021. So, I think that I don't think it is far more important to get the first one than it is to get the second one. And whether or not the second one makes a difference is not totally clear to me. I will also say that it's become pretty clear that people with CF are not at, there's a little bit higher risk of getting the COVID and the consequences of COVID, but it's not way out of range compared to the general population like I was worried about back in 2020. It seems like people with CF are sort of on the normal spectrum of COVID responses and risk from COVID. And now 5 years into the epidemic, that has waned a lot also. So I don't have a strong recommendation about this. That's a very, very long way of saying that I don't have a strong recommendation about the second one because I'm not sure what benefit it offers. Sort of in April, like if you in April or May of 2026, I just don't know what it would buy at that point.
Does that extend to people with CF related diabetes? I'm not keeping super current on all the different COVID things now, but last year diabetes was a little bit more of a risk factor with that.
Yeah, I think diabetes is still more of a risk factor. It has a lot to do with how well controlled diabetes is. I think that the first vaccine is by far more important. I don't think there's harm to getting the second vaccine. I'm just not sure that it offers that much benefit on top of the first one. I would never tell you not to. I'm
I
not
did,
sure. Just literally
I had a
not.
question,
Yeah.
I had a question around the vaccine too. So I don't know what's happening right now with the COVID vaccine as out there, but
Hmm.
is there going to be a way that family members,
Yeah.
is this
So,
give a cop, family members will get access to the vaccines? Because my husband, I'm going to make him get vaccinated, and
yeah.
if it's not allowed, I'm just going to tell him to go in and say he's got CF, just get
Yeah.
his vaccine.
So,
Because he can't ask it.
the State
Yeah.
Department of Health, the State Department of Health has issued basically a standing order that anybody over 6 months can get the vaccine. So, uh, you everybody, including your husband, should be able to get a vaccine. And if not, you can make a claim that you have something, or you can just go find a different pharmacy that will actually do it. But the State Department of Health has a standing order for everyone. So it in Washington State, it shouldn't be an issue. If it, I have told people if it turns into a major problem, you know, drive to Canada and Surrey, and they'll give one to you there. But I don't think that that's going to be an issue.
Okay.
Anybody have any burning last questions? I think this is, I will say that I just want to say that I appreciate everyone joining here. This was in part a trial run. We had talked about setting these up to foster a sense of community amongst people who have CF, and to give you all an opportunity to ask questions that maybe it's hard to ask at a standard doctor's appointment. And so I appreciate you all participating, and I hope we've accomplished some of that goal. And I think that there's at least discussion of doing this with other people in the CF space in the future. So this seems like it was successful, or I think it was successful. So thanks everyone for participating.
I have another question.
Yeah.
Um, as I mentioned, I'm on ivacaftor. Is that going to become generic at some point? And what are the ramifications if that happens? Am I not going to be able to? Well, I should probably still have insurance coverage, but are they going to stop making ivacaftor because it's not making money to the drug companies if it's generic? Or what are your thoughts on that?
Um, it actually is going to become generic. I can't remember the exact year. I think it's before the end of the decade. I can't remember when it goes off patent. But patents are for 20 years from the time that you file for it, and then it was approved in 2011. So it's sometime around the latter part of the 2000s that the patent was applied for. There, I think it's very likely that there will be generic manufacturers of ivacaftor only. One is that there's there already are there are countries that are just making these drugs, basically flouting the international patent restrictions because Vertex charges so much. So there are South American drug manufacturers that actually make all of these, Trikafta and Kalydeco and such. So they're already out there making it. Ivacaftor is a component of Trikafta and Alyftrek, or Trikafta, not Alyftrek. So Vertex has to keep manufacturing it so that they can make these other triple agents. So I wouldn't worry that it's going to disappear from the market. I don't know how much it's going to get, what the pricing will be. It's almost certainly going to be, probably an order of magnitude less than what it is now for insurance companies when it does become generic. So the answer is I can't remember when it comes off patent. I'm sure it's going to stick around, and the pricing I don't know much about, but it'll probably be in the same ballpark as other single agent drugs when it does become generic.
Okay, thank you for that.
Yep.
With that being said, I want to thank everybody for joining us today. And honestly, Dr. Danekar, you are genuinely one of the coolest humans I've ever met, and I am so personally honored that you're my doctor. To have a doctor that actually cares. You've been a huge support for me. I remember when I went off to some obscure Asian country and you shared your information just in case there was an emergency. The idea that like a doc you cared was incredible. And fortunately, the only thing I got was food poisoning from eating raw pork. But aside from that, you were still there. So thank you for
Yeah,
being a truly caring doctor to us all, and thank
you're
you for your
most welcome.
participation today.
Yeah, yeah. My pleasure. It's a joy. It really is.